Dr. Howard Liebman. He's the professor of medicine and pathology. He's an author or co-author of over 170 peer-reviewed publications, review articles, and chapters. He's presented over 200 lectures across the United States and across the world. He's served as the former chair of the Massachusetts Governor's Task Force Subcommittee on Experimental Therapies and Clinical Trials for AIDS. He's a medical advisor for the Platelet Disorder Support Association and a member of the Cancer Thrombosis Guidelines Community of the American Society of Clinical Oncology. He served on several grant review committees for the National Institute of Health. He presently holds the Donald I. Feinstein Endowed Chair of Hematology at the University of Southern California, Keck School of Medicine in Los Angeles, which is how I know Dr. Liebman, although he may not remember me. Dr. Liebman, about 25 years ago, was the hematologist that led the lectures when I was in medical school. And when his name came across my email as somebody that could speak to us, I jumped at the opportunity. It's incredible to be able to remember a lecturer that you had a few times 25 years later. And so I'm sure hopefully all of you will remember this grand rounds 25 years from now. In addition to his academic responsibilities, Dr. Liebman is an attending staff member of the LA County USC Medical Center, the USC Norris Comprehensive Cancer Center, and the Keck Hospital of USC. Dr. Liebman is also on the forefront of research in thrombotic and hemorrhagic disorders. His lab is currently studying the genetic factors responsible for thrombotic diseases, including venous thrombosis, PE, and arterial thrombosis. Like I said, he's internationally known for his work in relationships between venous thrombotic disease and underlying malignancy. He has been the principal investigator on several clinical trials in the management of immune thrombocytopenia, which he is going to speak to us about today. So thank you very much, Dr. Liebman. We got a round of applause. Okay, good.
Thank you, David. Now, do I really have to give the talk? You already said it was a brilliant talk, right?
Yeah, we're done already.
Okay. This talk was developed by the International Society of Thrombosis Hemostasis. So it was obviously independently funded by the major, might say, international group that studies thrombotic coagulation and platelet disorders. And it is a CME talk, and so I want to emphasize that it is also targeted primarily for hematologists. But what I'm going to do is diverge from some of the things that are provided here to talk a little bit more about autoimmunity, because the most common cytopenias, autoimmune cytopenia, is immune thrombocytopenia. And we now have come to term it not a disease, but as a syndrome, and I'll try to explain why, because it relates to almost all autoimmune disease. So these are actually my younger colleagues, Cindy Newart, who actually chairs the guidelines committee for the American Society of Hematology, and then Hani Al-Shamari from the Mass General, and Adam Kukor from Penn. We turned it over to the younger generation, but us older guys actually did get a chance to review the presentation. Let's see. All right, so what I'm going to discuss is treatment considerations for what's called persistent chronic ITP. I'm going to define that, okay? And we're going to talk a little bit more about really what is the diagnostic criteria for immune thrombocytopenia. You're going to evaluate the clinical information of the drugs we use today and somehow really understand the heterogeneity of responses to these drugs and why you could somehow even predict who's going to do well with an agent, who's not going to. And then develop the individualized treatment strategies for patients, because the concept is this is developed in a relationship with your patient, like all aspects of internal medicine. And speaking as a classical hematologist, basically I'm just an internist with a big interest in hematology. So here are some of the pre-test questions. So you have a patient and you're going to want to treat him, and you use drugs such as romiplosin, eltrombopag, avatrombopag. How do they work? Do they reduce production of antiplatelet antibodies? Do they decrease platelet removal, blocking binding of autoantibodies to megakaryocyte receptors, or activating thrombopoietin receptors on megakaryocytes. So obviously for hematologists, you probably know this, but I think it's worth knowing about these drugs because they're being used actually off indication for other causes of thrombocytopenia. A patient with ITP, 4 months, decides to undergo treatment with rituximab. Now, 2 months later, despite a slight increase in platelet count initially, she's now requiring treatment again for a platelet count of only 12,000. So you can't get her off of steroids. And what are you going to do next? You can repeat the rituximab. You can do a splenectomy. You can use a thrombopoietin receptor agonist, which we'll talk a little bit more about, or you can see what happens at 12,000 platelets. So now we've got a 32-year-old male with persistent ITP, has received treatment with steroids for his ITP. His most recent platelet count is 17,000. He doesn't like the side effects of steroids and wants to get off them as soon as possible. He would prefer not to take a daily medication. So what do you want to treat him with? Avathrombopag? Well, talk about that a little later. Splenectomy? We'll talk about that a little later. And we're going to talk about intravenous immunoglobulin and finally ramiplostin. So if you know what you might want to do on this young man, and again, at 32 in my age, that's still young, make that choice. And finally, the following drugs in development for the treatment of ITP. Which one works by inhibiting the neonatal FC receptor, the FcRn receptor? And we're going to talk about that receptor because it has relevance to a variety of autoimmune disorders. And in fact, for one autoimmune disorder, one of the drugs that inhibits that receptor is now commercially available. So it's an autoimmune disease, which is actually a broad term that hides our ignorance about why people develop these cytopenias. The definition actually was revised in 2008 at a meeting that was held in Vicenza, Italy, by Francisco Rodriguero, who brought together all the international experts on ITP to that city from literally Australia, Asia, South America, and North America, and Europe. And unfortunately, I was giving a talk at the same time in Florence on thrombosis, AJ Carr's meeting. So I wasn't attending, so I got stuck having to review all the papers that came out of this meeting. But independent of that, they looked at the fact that in reality, there are populations in the world that for genetic reasons have platelet counts less than 150,000. And while most of our labs define the 2 standard deviation platelet count as 150 to maybe 450,000, in fact, there are communities actually in Sardinia where there are intermarriage in the villages where they've found that populations have platelet counts of about 110, 105,000. So obviously less than 100,000. And you have to evaluate because now it becomes a diagnostic algorithm. What is the cause of it? And in reality, it's a diagnosis of exclusion. But in definition, despite the exclusion, the only way you're going to prove it's an autoimmune disease is that it responds to immune modulation, such as steroids, intravenous immunoglobulin, Rituxan, any drug that modulates the immune system that can induce a response tells you it's an immune-mediated process. But it's very heterogeneous. If you look at the figure shown here, this was from a manuscript that was published the same year as the original redefinition of the disease in 2009. That came out of a discussion between Doug Seams at Penn and Jim Bussell at Cornell and myself about really what is secondary ITP. And so we wrote this paper and we put together this figure for the amount of the paper that was published in Blood. And what we actually found is, in fact, 20% appeared to have other autoimmune or immune dysregulatory disorders, obvious lupus, antiphospholipid antibody syndrome, but also even immunodeficiencies such as common variable immunodeficiency. Why with hypogammaglobulinemia would you have a clone making an antibody against platelets? Also, autoimmune lymphoproliferative syndrome, where in fact you can't shut down the activated T cells because the fast ligand system is defective. So in fact, when you activate your immune system via the T cell, when the stimulus is gone, it should deactivate, and it fails to do this. And these patients get autoimmune disease, lymphomas, and a variety of other disorders. And then there are actually other aspects such as post-solid tumor or bone marrow transplant. Patients who actually have had ablation of their immune system, such as patients with multiple sclerosis who receive alemtuzumab. 2% of those patients will develop ITP, although it is without a doubt the best drug for long-term responses of patients with multiple sclerosis. And then finally, there is the issue of infection. And the three classic infections that are well described as HIV, which you could expect is a disorder of immune dysregulation. Now, hepatitis C has been clearly shown to be associated with a variety of antibodies, including rheumatoid factor and other things leading to cryoglobulinemia. But in fact, it's frequently associated with ITP and thrombocytopenia independent of liver disease. And that was shown by a paper at our institution by Sandeep Rajan, who have actually showed that a number of patients with hepatitis C infection, but no active liver disease, normal spleens, actually had severe thrombocytopenia and were responsive to treatments such as immune modulation with intravenous immunoglobulin. And finally, Helicobacter pylori, which still is an unexplained reason why it can be associated with autoimmune disease, but we know it can cause lymphoproliferative disorders in the gut and cause gastric lymphoma. So we know the immune system is being stimulated with this, and there are patients early on with this diagnosis who can undergo a remission with treatment. But when they get their platelet counts under 10,000, they're less likely to respond. And we'll talk a little bit why that would happen. Finally, the question that emerges is that, what about those primary? In fact, in the manuscript that we wrote it in 2009, we came to realize, and we'll talk about that so-called primary ITP, where you can't consider these other aspects, is heterogeneous in itself. And probably there is now really no such thing as primary ITP. And the end result, the title of that paper published in 2009 was The ITP Syndrome. And that holds true to almost any autoimmune disease. You ask your rheumatologist, well, what makes lupus? And they're going to tell you, well, they can have this, they can have that, etc. But in reality, there is heterogeneity in all autoimmune diseases. So this is the incidence, and this is a paper looking at the incidence from the United Kingdom. But what I want you to look at is there are really a lot more here than just what we're talking about. It talks about the heterogeneity. In the pediatric cases, which develop usually before the age of 10, often with their MMR vaccination triggering it, 75% of those children are going to undergo a spontaneous remission. And interesting enough, it tends to favor development in males. But as you get towards puberty, you begin to see a switch in the gender-related incidence. And therefore, in the periods after puberty and as a young woman in the childbearing years, that population has the highest incidence during those years. And you can see here that actually, and by the way, this curve has been repeated from the Scandinavian cohorts, from Norway, Denmark, Sweden, from the Taiwanese cohorts, and from the Korean cohorts. So it makes no difference by ethnic differences. In reality, this pattern is repeated throughout the world in terms of the incidence of ITP. But remember, this is the incidence of ITP is greater because, at least in the adult population, this becomes a chronic disease in the majority of cases. But we'll talk about a little bit about the importance of this gender distribution in terms of treatment. But the real problem is ITP in the overall population is the disease of the older. As our immune system ages, you see the rising incidence. And in fact, in the later years, it becomes a predominantly male disorder. And there you're now dealing with treating patients who have multiple comorbidities. Any internal medicine doctor knows that we are treating patients with a disease where you have to immune modulate them, that they are, for a problem of thrombocytopenia, they may be on aspirin because they have had coronary bypass procedures, or they've had stents placed, or they could be on an anticoagulant from a thrombotic disorder. Because in fact, remember, antiphospholipid antibody syndrome can also occur in the background of immune thrombocytopenia. So the difficulty of managing the bulk of patients that have persistent and chronic ITP falls upon treating people. In most of the clinical trials, the average age of individuals entering clinical trials, which reflects more likely patients who are somewhat refractory, are 50 to 55 years of age. So when we talk about autoimmunity, we think about obviously failure of immune tolerance. In the adaptive immune system, obviously we have central immune tolerance. For T cells, it's the thymus. For B cells, it's in the bone marrow. There's deletion of autoreactive populations in both targets, both for the B and T cell. But there are obviously, this is not a perfect system, and clones escape that have the ability to cross-react with self-antigens, even at low affinity. But that may be significant because they're controlled by peripheral mechanisms. There are T regulatory cells, FOXP3 cells that are up there that are basically able to shut it down. There are T cells that can express CTLA4 that can block the checkpoint interactions. And there are actually B regulatory cells that have been described. So there's a variety of controls that peripherally. Now, those systems can fail, and they often can fail under great immunostimulation. It's been shown that although if you ablate the bone marrow, example for a bone marrow transplant, or more important, if you ablate it in relationship to treating multiple sclerosis with alemtuzumab, the homeostatic recovery of cells actually leads to an irregular recovery, and in fact, autoimmunity evolves out of that. So one of the reasons many neurologists don't like to use alemtuzumab, although the 6-year results in terms of relapse are better, is that within the first 4 years, there's a huge number of autoimmune events, ITP being it, but 60% get thyroid disease, and mostly Graves. They get renal disease, they get a whole heterogeneous, we've seen TTP at our site because of the big MS group, our institution. So again, immune dysregulation emerges anytime the bone marrow is disrupted, or if the bone marrow is driven with vaccination, you can actually, in that issue, antigen-mediated homeostatic expansion is very rapid. Within 1 to 2 days, you can increase the populations, and what happens is you can drive over your immune regulatory systems. So you get these clones, okay? So you get a clone that's actually going to do it, a T cell clone that's escaped immune tolerance regulations. You go make antibodies, and here's the problem. They're going to bind to platelets, and platelets are going to be destroyed. But in the process of this, they're going to pass information via the dendritic mechanisms to make new antibodies. And it was shown years ago by Robert McMillan, one of the great investigators at Scripps Institute, which actually showed that older patients with ITP had years now are making antibodies against multiple platelet targets, including cytoplasmic domains of platelet antigens. You're constantly processing, and what is emerging is new clones, now independent of the original escape clone. Those antibodies also, sure, if they can bind to platelets, they're going to bind to the megakaryocyte. And Diane Nugent and Robert McMillan showed that, in fact, those antibodies, if you isolate them and put them into culture of trying to drive out megakaryocytes proliferation, you can block proliferation in vitro. So in fact, those antibodies are capable, but also you generate cytotoxic T cells, CD8 lymphocytes, and they can directly damage the megakaryocyte. And in fact, their French have shown that they exist in the spleen and they may contribute to splenic destruction of platelets. So altogether, you have this cycle that leads to decreased production by damaging the megakaryocyte. And although your pathology will say, well, megakaryocytes are present and normal, if you do an EM, you're going to find those megakaryocytes are showing the targets of apoptosis, vacuolization, and changes that you can only see under EM, and decreased production and increased destruction. So that's the component of disease. And your goal as a physician is try to regain immune regulation. So the goals of treatment, well, they're very easy, okay? And they're going to try to prevent the hemorrhagic manifestations. Every time I see a new patient comes into me, they're in panic because the ER doctor has told them, you got to get this taken care of right away. You got to bleed into your brain. But in reality, intracerebral hemorrhage is actually very rare. And what usually defines it is older patients, hypertensive patients. But even in that population, it's still rare, or being on antiplatelet agents or anticoagulants. And so in reality, actually, of over 150 cases that I've seen referred to me from the outside, and that's not including the my institution cases found. In reality, I've only seen one patient who had a history of an intracerebral hemorrhage. So in fact, it is a rare event in the background, even with platelet counts that are 2,000 to 3,000. So the brain does not like to bleed, and in fact, it prefers to clot. So in reality, you can see that that's a rare event, but you have to take your time. And if you have platelet counts that are above 30,000, you have plenty of time to sit and think about your best strategy and confirm that you have an immune-mediated thrombocytopenia. So you want to prevent the hemorrhages and actually those manifestations. And most important, you want to choose something that's going to not impact the quality of life. And really, that's where you have to understand your patient. Okay, what is their goals? A young woman who describes horrendous menses. One of the women who is on our rilzabrutinib trial, and we'll talk about that drug. Every time she was one of our county hospital patients, every time she had a period, she has to be hospitalized and given intravenous hemoglobin and steroids. And she's a single mom who has to take care of her child. So she had to find somebody to take care of her kid when she had to come in the hospital. So that's an example of the impact of life. And so finding a treatment and putting on a trial was the best thing, because at high doses of avatrombopag, a thrombopoietin receptor agonist, and 40 milligrams of prednisone, we couldn't get her platelet count over 3,000 except with IVIG, and you can't do that every day. So luckily now she's a responder to the clinical trial drug. So, and then obviously it'd be great if you could take them off and get a remission. We don't talk about cure, okay? Talk about a remission. And we've seen patients, and I have seen patients who have been in remission 12 years, and more recently when they got their COVID vaccination, relapse. So the International Working Group decided to divide the disease into 3 stages. And the reason why is that still, even in adults, and particularly in children, within 3 months, there is spontaneous remission. It's only about 20% in adults, and still it can occur. And in adults in particular, even children, there's some continuation into the phase afterwards, but that represents maybe only 10% to 15% of patients who are going to get a subsequent remission. So these 2 points are important. And obviously the target most often of focusing on treatment is this period. Because in fact, while we treat with steroids and we try to wean them off within 6 to 8 weeks of steroids here and see if you get a remission, that population that is going to get a remission. But if they don't, then we're going to have to think about other strategies, because I think it's a crime against humanity to leave a patient on long-term corticosteroids. And I've seen cases that have been on the drug for years because that's the only option their so-called hematologist thinks is reasonable. So this is an algorithm. I hate them somehow because they're never as simple as they think. Goal is to actually find a safe platelet count. Well, we know that a platelet count over 50,000 is more than adequate. In fact, over 30,000 in most cases is adequate, but it depends on the lifestyle of the individual. If they're playing football or if they want to do active sports, you may want to be a little higher. So obviously this group, the question occurs, do you want to treat them? Obviously, you may want to treat them in this range because you may want to prove it's an immune-mediated process, usually either corticosteroids, but again, less than 6 weeks. The International Working Group says 8 weeks. You get them intravenous hemoglobin. There's a whole story about how that may work. But altogether, in fact, you want to see if they're stable above this and they're patients that have no other contraindication in terms of their risk of bleeding. Younger individuals, you may want to just follow them for a while and see if they do obtain a remission before you begin treatment. And then we talk about you treat them on steroids, intravenous hemoglobin are the primary. And then if they fail or they go into the persistent phase, then you want to think about your choices here. So here's an example, and I'm going to use some cases. So here we have a 28-year-old woman on oral contraceptive. Pick an account. Let you figure this out. This happens at every grand rounds in every institution that I've ever spoken at.
Yeah.
You'll get extra credit for your credit.
All right. So obviously this would be a classic primary ITP. Young woman develops thrombocytopenia and notices primarily by heavy menses, not any other major bleeding manifestations. And she's got a platelet count of 18,000, so that's not so terrible. You have time to really think about it. And everything else looks normal. So what are you going to do? Well, you could think about, what do you want to do? Well, the classic thing is to give her prednisone, 1 milligram per kilogram. That's an immune modulating drug. Rituximab is, but why use that drug? It has complications far beyond prednisone. Intravenous immunoglobulin, well, it's an expensive drug, and why use that drug at that dosing levels, which would be thousands of dollars, when prednisone, you'll know usually within 10 to 14 days if you have a response. But you're not going to make that her major treatment, so you start weaning her afterwards, and you find that when you get down to 10 milligrams, she's back down at 15,000. So what are you going to do now? You're going to increase the prednisone again and play the cycle that I've seen done in the community. And historically, before we had newer agents do it, you could do a splenectomy. Splenectomy is not benign. We actually knew that after you take out the spleen, with example, hereditary spherocytosis, there was an increase of thrombosis that occurred long afterwards. Something's going on when you take out the spleen, independent of the fact that we worry about overwhelming sepsis and infection. And that's been now subsequently confirmed in terms of this disease. And what are you going to do? You can try rituximab. And this we'll talk about is the perfect patient for rituximab when we talk a little bit more about it. All right. So what do we do with rituximab? Rituximab is trying to hit the CD20 antigen on the B cell. And in fact, until you actually mature into a plasma cell, there are targets that are going to hit it. Obviously, its target is to reduce antibody production, but the long-term duration of this we'll talk about is very short. And in certain populations, the response at 1 year is very poor. And that is the prejudice and link between being a man and a woman. And we'll talk a little bit more about that when we talk about rituximab. Splenectomy, okay, obviously removes a major target of clearance, but also a major target that contains plasma cells, okay? Spleen is rich in antiplatelet antibodies. It's shown Robert Millen years ago, and it also has many plasma cells that the French have shown, even after rituximab treatment failure. And finally, the thrombopoietin receptor agonists will amplify production of platelets, but it actually is what you need to think about what thrombopoietin is. Thrombopoietin is 75% homologous to erythropoietin, but it's not a growth factor. It's an anti-apoptotic factor. With erythropoietin, when the bone marrow matures out to the BFUE stage, where they express the EPO receptor, it's waiting for engagement with erythropoietin. If it doesn't see it, those cells undergo apoptosis. So you actually don't see maturing red cells come out. In fact, if the bone marrow stem cell is missing the thrombopoietin receptor, that child is born with almost no platelets, but within a short period of time goes into total aplasia because it's necessary for stem cell self-renewal. It's an anti-apoptotic factor. So think about this issue. And so what's the advantage of this? Why would it work when you have antibodies attacking megakaryocyte? It gives resistance to the megakaryocyte against the effects of the antibodies and even the T cells by its anti-apoptotic pathway. So splenectomy is successful. It's a historical thing, but all the literature is based upon cohorts that were treated in the past where the only other choices were steroids and later IVIG. And reality, the splenectomy was often done at 6 months because the old definition ITP was you were chronic after 6 months. So there were a lot of individuals, and particularly young women, who had their spleens removed who could have gone into a spontaneous remission. So that 65 to 70% response rate, even shown later on in a systemic review by Jim George at University of Oklahoma, found that in fact, when you got it past the age of 50, the response rates went down. He didn't look at gender issues, but probably I would have suspected, and there are some other studies that suggest that women were more likely to do better, particularly young women, than men and older men in particular. So it's obviously, you can't predict response. There's not a good system. There have been some studies looking at where platelets go when they're indium labeled, but there's only one place that's ever done it well. It's in London. The loss of immune protection, obviously it's been shown in studies that there's persistent risk of infection. And the most significant issue is if you look at the curves that have been published by Soames Boyle in Blood and following these patients out in a historical cohort, what they found is that there's a continual rising risk of thrombosis, both venous and arterial, compared to ITP patients who did not undergo splenectomy. So there's something about removing that spleen that makes you more susceptible to vascular events. So here's an example of really what the remission rates are in terms of rituximab. And what you're going to see is that, in fact, rituximab is fine. But in reality, by, in fact, 5 years, only 20% of adults are going to have a sustained remission. It's identical to the natural history of the disease historically on steroids alone. A recent paper in the New England Journal of the FLIGHT study where they added mycophenolate early in these patients, and they showed you could double the response rate, but at 2 years, but at actually that period of time, the steroid alone cohort, it was still only 20%. So that is the natural breakdown, and most of those are going to be women, and women in the younger years. And what was subsequently shown in studies by Jim Boussel and by Marc Michel in the French group, which was the cohort for this group that's shown here, is that it's women in the childbearing years treated within the first year of life are the ones that go on to long-term remissions. And a similar study from the Italian cohorts found that, in fact, men at 1 year given rituximab, 17% response rate, but counts over 50,000. This is not complete responses. We're talking about response rate over 50,000. So you could ask why this gender differences, but it's in those early years. But after the age of 50, in both cohorts, responses decrease. And after 2 years of disease, response rates are lower too. And the duration is lower because the disease is evolving, as we talked about originally, over those 2 years. So again, there are lots of studies. We do the autoimmune dosing when we pick it, and so we use it only in the young women, like that would have been this young woman. Primary ITP, no secondary causes, and we do 1,000 milligrams 2 weeks apart. Okay. And then, but you can use this lymphoma regimen, etc. And even 100 milligrams over 4 weeks. There's something about that cohort that's going to be responsive. It doesn't make a dose difference, except it's more expensive, maybe. There's no benign therapy. It's, I mean, it's such a thing. Interesting enough, there's a group that gets significant hypogammaglobulinemia. And the French showed this, and they immediately progressed. And we actually now are aware that many of those had mutations in important genes that are linked to common variable immune deficiency. The IKZF1 mutation, actually, we saw a patient who was treated for Evans, got a complete remission for his Evans as ITP with rituximab, and subsequently went on to develop hypogammaglobulinemia. When we germline mutation, we found he had this unique mutation. So over a 17-year period, he progressed from Evans syndrome, hemolytic anemia, ITP, got a anti-CD20 antibody, which wasn't Rituxan, another clinical trial, but another drug called vilastuzumab, then went on to get a lymphocyte proliferate, a lymphocytic pulmonary infiltration with splenomegaly to respond to steroids, and they went on to get severe hypogammaglobulinemia and had a mutation that's well described associated with, by the time he's now in his 40s, associated with common variable immune deficiency. So again, that's one of the risks to think about. And then finally, you can think about, may take time to have a response. Usually they'll respond easily within 2 to 3 months maximum. And long-term remission are less than splenectomy, yes. but if you select the group, you don't waste the drug on other people. Finally, thrombopoietin receptor agonists. These are the drugs that are developed to induce effective megakaryocytic production of platelets in this disease. The first one was ramiplostin. It's given subcutaneously. The original clinical trials, the patients, once they received a stable platelet count after a week, they were sent home to self-inject at home and only came in once a month. But the way the FDA has approved it, you still have to come in every week, and they usually get a platelet count. And after months and months of this, they're sick and tired of seeing the hematologist or the lab technician or the phlebotomist once a week. Thrombopoietin was the first oral agent. Okay, it has a lot of problems. It is a chelating agent. It binds calcium and other divalent metal cations. It even binds iron, and the pediatric population has been associated with developing iron deficiency. But is effective, and the dosing regimen is very strange. You start at 50 unless you're Asian. You start at 25. The metabolism, but in reality, the most likely is to start at 75. If you respond, you can start going to every other day dosing, et cetera, et cetera. Those aren't in the label, but people are trapped by the label, and insurance companies treat you. And finally, there's avathrombopag, the newest agent, can be taken with food, doesn't have hepatic toxicity, which is seen with thrombopoietin. Very potent drug, particularly at the higher dose, 40 milligrams a day, and maybe the match of ramiplostin. In a recent paper that we published with the group from the Mass General and Penn and University of Washington, we found in the switching studies that, in fact, many patients who had difficulty in thrombopoietin and ramiplostin sustained a good platelet response with avathrombopag, and a follow-up study shows long-term responses that are quite good. Now, the old story was that every time I talk to a patient, physician in the community about a patient I've seen in consultation, I suggest a TPO agonist, and they tell me, well, they're going to be on that drug for life. Can't you get them off the drug? And the first story is there's nobody's on a drug for life. Okay? They're either going to fail it and need something else, or interestingly enough, we now know that patients can be weaned off these drugs who have good response, can go up to 100,000 platelets, and be weaned off them, and about 30% either on ramiplostin, a study by Adrian Newland published in British Journal of Hematology, or two studies, one called the TAPER study, which was a thrombopoietin study, or the Stop and Go, which is a differential thrombosis study, showed that about 30%, if you wean them off the drug, will have a sustained response, at least greater than 6 months, sometimes out to several years, with platelet counts above 50,000, in particular ones over 100,000, can maintain that response for many years, actually. And we have a number of patients who obtain their remissions on thrombopoietin receptor agonists. It's more likely to work if you use it earlier in the persistent phase, before they develop a more complex autoimmune pattern. So talk about this. I've mentioned these things. The big thing is the cost, but it is not a lifelong issue, and it's not curative in the majority of patients. And they've changed that now because of evidence that you can get a drug-free response. So what are your choices? And I don't want to spend a lot of time on this. Okay, if you want to use rituximab, you're going to pick it for those young women who have the best response. TPO agonists rather than Rituxan if they don't want to get exposed to this. If they fail Rituxan, go on TPO agonists. Splenectomy is an end organ, and in fact, in reality, there are a variety of decisions where I don't do splenectomy. We've only done one splenectomy in the last 20 years at our site. Okay, thrombopoietin receptor agonists, low toxicity, reasonably good benefit. Cost is always an issue. And as it says, rituximab in certain populations, and we talked about the younger patients in the first year. And obviously now the guidelines say, don't even think about splenectomy for the first year. You have choices to go forward, and the patients don't want it. And these, I'm not going to spend a lot of time here. This is in the ASH guidelines. If you're a hematologist, you can look this up. But it's even going to change. It's going to talk about rituximab really targeting a specific populations in favor of this in the newer guidelines. Okay, so in case one, the choice is going to be, the TPO agonist. So here you got 18 months later, and she basically, has not achieved a sustained response from rituximab, okay? And you go ahead and which of the following FDA-approved treatments for refractory? There's danazol, that's not FDA approved for, cyclosporin, that's not FDA approved, mycophenolate, and the only one that's FDA approved is fostamatinib. What is fostamatinib? So here we're going to talk about how when you have an antigen antibody complex is cleared, it engages with an FC receptor on a macrophage, okay? And what that does is trigger a pathway called the Syk kinase pathway. And this is an inhibitor of Syk kinase, okay? And so those that inhibit phagocytosis and inflammatory responses to the antigen antibody complex. The problem with fostamatinib is, okay, is that it can't totally saturate because of its toxicity, which is diarrhea and hypertension. And so the degree of saturation of the Syk kinase leaves the ability to totally shut it down. It's approved for this indication, but the sustained responses are kind of mixed. And you usually start 100 milligrams twice a day. If you're going to respond to it, you respond within the first probably 4 weeks. If you don't respond in 4 weeks, even if you go up to 150 milligrams, you don't see responses. If you get at least a partial response, you might try 150, but the toxicity frequently means you're going to be back at 100 milligrams. But it tells you that there are other targets. And when we talk about the Syk kinase, we're going to talk about some new treatments that actually have another pathway to inhibit the Syk kinase and actually modulate the B cell antibody production. Because the more we understand about the pathways of the enzymatic targets that are involved in phagocytosis and signaling within basically B cells and T cells in the immune system, the more we have options to treat these patients. And that leads to a lot of the new therapies. So the overall response is, if you're new, it seems to be better than not. But response means to just get the platelet count up over 50,000. But in sustained responses are only much lower. And second line therapy, you know, is basically, yeah, it responds initially, but very few patients, only about 20%, have a good stable platelet count that is defines a response greater than 50,000. And here you can see the results, and the ones that are circled are the so-called sustained responders by the initial clinical trial. Okay. But many of those patients I mentioned were refractory cases, okay? And also subsequent reanalysis found that some of the patients put on the trial did not have ITP. And that's another issue, that in reality, even at our center, when we've looked at the cases that we've seen, and even some of the ones we've gone back and looked again, 15% of patients that come to us don't have immune thrombocytopenia. And the most frequent cause is an underlying genetic platelet disorder associated usually with a megakaryocytic, I should say not mega, with a megaplatelet syndrome, so it'll have larger platelets. How many of you, when you look at a CBC, look at the MPV? Many hematologists don't. But studies have shown that if the MPV in someone with thrombocytopenia is greater than 12.5, you better consider the possibility that you have a genetic inherited platelet disorder. And in fact, there's so many of them out there, it's surprising. We actually have described a number of them. So let's go on, okay? So you treat the patient and her platelet count 75,000, that's great, okay? So when you make these choices, you got to talk to the patients about the drugs, you've got to explain it. Okay, and you've got to think some else about what are the predictors of response. You talk to them age, gender, and what are their treatment goals is important. It's like in everything you do as an internal medicine doctor. Okay, and that comes to the decision with that shared decision making, because you have to talk to them about the toxicities. So let's just go through a few cases real fast. 17-year-old ITP 6 months ago, responded well, steroids, been unable to wean from prednisone. Currently 18,000 on prednisone. Reports fatigue. That's really common with ITP. There's a lot of evidence they have interleukin 6 elevations due to the underlying autoimmune disease associated with fatigue. And stop playing football, platelet count. What are you going to do? What do you recommend? Well, give them a thrombopoietin receptor agonist, get his platelets up, and you can control it if that's the choice. Case 3, 28-year-old female, 9 months ago, her platelet count off treatment is 20,000. Minimal bleeding most days, it's very heavy menses. Hematologists have been treating her with dexamethasone. at a time or periods to reduce bleeding, but that's still a steroid repeatedly. She's anxious about it, becomes tearful and visits steroids to disturb her sleep, and dexamethasone, if you're an older patient, can make them frankly psychotic. Heavy periods have caused her to limit her social interactions, all of these things. What do you want to do? Well, to cure her ITP. Well, you try rituximab, particularly within the first year, that's your best chance. Finally, you've got a 68-year-old gentleman, ITP 5 years ago. He's had a long time. He's got a difficult disease. He's getting white fluctuations of rhombopoietin. I would try to switch him to have a thrombopeg if I had that patient. He's on anticoagulation for atrial fibrillation and an embolic stroke he suffered 1 year ago. You don't want to take him off his anticoagulation. Okay, we assume he's on apixaban or maybe rivaroxaban, depending on what his insurance gives him. He's got some weakness from that. There's a risk of fall, and his cardiologist is concerned about serious bleeding. What are you going to do? Here you might consider splenectomy, but remember his age, his response rate is going to be less, and he has to go through surgery, and there's a long-term risk of thrombosis, but yet he's going to be on anticoagulation for life for his atrial fib, unless he can get an ablation or something else done. But the point is that still, it's the most likely issue that's going to give him a sustained response, and can be done safely if you basically manage the patient well and really manage his anticoagulation well before and after his surgery. So now we got a 70-year-old woman, ITP 30 years. This is the ones that drive me crazy. Numerous treatments in the past, splenectomy, rituximab, you've gotten everything, okay? And they probably had her mycophenolate, azathioprine, everything else, maybe cyclosporin. So what are you going to do? You got to put her on a clinical trial. And what I want to talk about is the targets that we're looking at today. One, Bruton tyrosine kinase, the BTK kinase, neonatal FcRn receptor, and the complement pathway. And basically all of these are considerations where you can find the trials. So I'm not going to go into, but as we talked about each, the neonatal Fc receptor is really important. It recycles your albumin and your monomeric immunoglobulins. It allows the antigen-bound immunoglobulins to be cleared and protects them. And that's the reason that antibodies live a long time. And it has that ability, by blocking it, to lead to rapid catabolism. Literally within 2 weeks, your IVIG can be 800, 900, and you'll see it down at 300 in 2 weeks. That's actually immunoglobulins without the Fc receptor have a very short half-life. Now, interestingly enough, it's very evident that when you drop them this low, the autoantibodies can in fact be brought to a level so low that in fact they can do it. And they'll recover, the antibodies recover, but the autoantibodies sometimes recover slowly. So what has been seen of the drugs used today, at least in ITP, one drug approved, efgartigimod, approved for myasthenia gravis, you can have reasonable responses that are sustained. Another FcRn drug that we studied in autoimmune in a patient who had failed Rituxan and had failed steroids, she went into remission for 2.5 years treated with an FcRn in that clinical trial. So why didn't she relapse right away, even though all her antibodies recovered? Well, that's a good question. But what you can see is that's the role of this drug. And then we design drugs that block the ability of the IgG to be recircled, but not the albumin recircled by this receptor. Okay. So the first is an antibody that directly interacts with the antigen site of that. And it does have a little bit of dropping of albumin, not significantly. And what you can see in this phase 2 clinical trial that was published in Blood Advances is that, in fact, they were able to get responses in the higher doses in, a significant portion of patients. Over 50% of patients saw a response in their platelet count. Okay. So that was an interesting observation. The phase 3 trial is going on now. The most recent one that has now been presented, and this is their phase 2 data, and by conflict of interest, I actually was on the steering committee for this phase 2 study. I had to walk away from involvement in the phase 3 study, but in the phase 2 study, to test this drug, okay, what we saw is that there was remarkable ability to respond across the board in a variety of patients at various doses. And so the drug is really very effective. And obviously, this is the one that was presented at American Society of Hematology meeting, is now going to be going to the FDA. But the overall responses in the phase 3 study is about 30 to 35%. But many of them are patients with long history. So if you block this receptor, you get rapid drops. The problem here with ITP is the majority of the antibodies are IgG1. And IgG1 has the highest affinity for the FcRn receptor. In fact, if you ever look at IgG subtypes, which medicine you don't usually do, the life, you see differences, between IgG1, 2, 3, and 4. And 3 is one of the lowest with 4. But the interesting stuff, the reason 3 is lower than 1 is it has a lower affinity to the FcRn. So the subtypes are really dependent. And I actually have a patient who we drove the immunoglobulins, who had one of the worst bleeding disorder, actually, interestingly enough, had a factor 5 inhibitor. There's no way to bypass blocking factor 5. Came in bleeding all over after they had played with him in another hospital. We drove his total antibody down with immunosuppression to 350 milligrams, and his INR was still 5.4. So what did I do? I convinced the insurance company to give me the regimen efragonimab that was approved for myasthenia gravis. That was really a dancing thing, try to talk to an insurance company. But they gave us to it for 8 cycles. The patient went into remission. I did drive his IgG down before I had to replace it to 120 milligrams, but his INR drove down to 1.4. So he had a high affinity immunoglobulin. And actually, we isolated some of his antibodies and sent to another lab that could study the affinities for the FcRn receptor before we published the paper. So again, it's a really important concept to understand that you can still do this by just catabolizing antibodies. Finally, complement inhibition. ITP, like hemolytic anemia, is not just a disease of the adaptive immune system, because the adaptive immune system, which is making antibodies, works with the innate immune system, the complement system. Now, I'm married to a professor also who's a big complement person, Dr. Eileen Weitz, and she is constantly reminding me about the complexity of the complement system, because once you learn the coagulation system, you don't have enough in your brain to learn the complement system. So I'm going to tell you that a remarkable issue is that we know that platelets can have C3b, because there are C3bs on receptors for it in the liver and other sites which can eat platelets independent of the FC receptors on the hemoglobin. And so these were refractory cases, multiple refractories, years and years, who still post-splenectomy had problems, and then went in and they put them on an inhibitor of the C1s, sutimlimab, which is approved for cold agglutinin hemolysis in the United States. And what do you see? Rapid responses, meaning that once you block putting C3b on those platelets, they are now up. The spleen is out on the patient, and yet the liver can't eat those platelets because they are really dependent on the complement receptor. And so impressive responses. Are they going to go to a phase 3 study? I don't know, because this is really a subgroup, but it really shows the importance of the innate immune system along with the adaptive immune system in autoimmune diseases. And we know that's true with hemolytic anemia. Complement C3b on the cell tells you a more difficult case to treat. So the last thing is the BTK inhibition. Bruton kinase is involved in the maturation of committed B cells to make plasma cells, but it has a lot of interactions, and it affects, you can see some of these. It actually inhibits platelet activation. It blocks IgE-mediated FcER activation and degranulation, and so they can study its inhibition by studying the release of eosinophil and mast cell effects. It blocks the IgE-mediated FcER activation and phagocytosis, because the BTK inhibits into the Syk system. And so if you could block making antibodies by preventing plasma cells and block FC phagocytosis, what are you going to get? You're going to get a rapid response. And here's what you see. Within a week to 10 days, platelet counts go up on these patients, all with platelet counts less than 30,000, highly refractory cases. This is the phase 2 data that's been published in the New England Journal. You get a phase 2 study in the New England Journal, says it has to be revolutionary. And overall, these responses in patients, particularly on the higher dose, which is the phase 3 dosing, 400 milligrams twice a day, with minimal symptomatic effects, you can see 40, 50%. These are really refractory cases. That young woman on 40 of avatrombopag and 40 of prednisone at 3,000 platelets now has 130,000 platelets off of steroids. Okay, so it's a very exciting issue. Now, interesting enough, ibrutinib, which is used to treat CLL, actually is associated with a bleeding diathesis because, in fact, the kinase, one of the kinases that blocks, is involved in signaling through the through the collagen receptor on the platelet. And so when it's blocked, actually, you lose that ability of platelets to aggregate when seeing collagen. Yet, ibrutinib was engineered to have the least interaction with other kinases. And so what happens is now it doesn't affect platelet function. And that's one of the important advantages. And so you can see here, when they look here at the ability of inhibiting aggregation, look at the collagen aggregation on the left, okay? Left here, you can see it can collagen aggregation. But here isn't affected by ibrutinib. So kind of getting close. So there are a lot of guidelines. There always have to be modified, and the subtleties really have to be studied. There's not a lot of high quality evidence to provide strong recommendations of truth, but as studies come on, we know more and more about the disease and its heterogeneity and the fact that in reality, even primary ITP is heterogeneous. And it helps in terms of basically making decisions based upon science and also being able to tell your patients exactly what's going to happen and what the probabilities are of getting a response. And finally, there are a lot of reasons that the ISTH could do this, because every company that was studying or involved in studying ITP or making drugs for it funded them independently, the International Society of Thrombosis Hemostasis, and they provided the money to the French Foundation. So these were the questions. Drugs to treat ITP, there are decreased, they affect a blocked no, they actually activate thrombopoietin receptors on megakaryocytes. They basically inhibit apoptosis. ITP for 4 months, decides to undergo treatment. Now 2 months later, despite a slight increase in platelet count, she requires treatment. What would you suggest? I mean, she's early in the disease. I would probably consider, since she failed rituximab, just putting on a TPO agonist, seeing how she responds and leave her on that for a while. I'm sorry. I would actually want to put her on a TPO agonist, least toxic. She's still early in the disease. She could still get a response even though she failed rituximab. A thrombopoietin receptor agonist, okay? First one, just to mention again, is activating thrombopoietin receptors. These are thrombopoietin receptor agonists. And then finally, 32 years old, persistent ITP. He's a male, treatment with steroids for his ITP. Most recent platelet count 17,000. Okay. Of the choices, the only one that you can offer him is splenectomy. And splenectomy, unlike rituximab, still has a reasonably good response in males early in their disease before they evolve. But be aware that he should think about all the complications besides immunization, which should be repeated regularly. Also warn him to take antibiotics. We can send him home with a script for antibiotics so they can get it if they have a fever at all, even before we think it might be viral. And also the issue of thrombotic risks. In a young person like this, don't be fat, okay? And splenectomy, okay? And then finally, following drugs to treat the FC receptor, that is the rosanolizumab. Okay, that's the top one. That is the one that blocks the FcRn receptor and results in catabolism. Fostamatinib is a SYK inhibitor. Sutimlimab is a C1s inhibitor that blocks complement activation by the classical pathway. And rilzabrutinib is the Bruton kinase inhibitor that's in phase 3 study. All right, I thank you. I may have gone over, forgive me, but I hope that you'll learn a little bit more about the heterogeneity of autoimmune disease. Thank you.
All right. Since we ran a little bit over for technical difficulties, which I apologize again, I'm going to go ahead and put up the slide that shows the QR code that you'll use for the evaluation, which will bring you to the place to get your CME credit. And again, Dr. Liebman is going to stick around for a little while to talk with anybody who's interested in talking a little bit more. I do want to say the reason why he's received teaching awards and why we liked him so much wasn't because he gave us the answers like he did today. He didn't do that, I promise. So I don't know if there's any questions. I'll start with one question. You talked about women of reproductive age having more difficulty controlling their disease compared with others, compared with women over the age of 50. And in thinking about women who have bleeding disorders, that they may often be put on estrogen to help control irregular menses. I wondering if you can talk about the mechanism of the role of estrogen and whether higher levels of estrogen, even in reproductive age women, contribute to ITP.
Oh, I'm gonna change that a bit. I didn't say they're more difficult. I say that at a period in those years, their incidence of ITP raises. So they have a higher incidence in males in the reproductive years, okay? So it's interesting that, in fact, the question of estrogens has occurred in many kinds. And what has been shown in a paper that was done years ago by, and it was also shown by Doug Seens, is in fact, estrogens enhance actually platelet clearance. And actually when they go into the menstrual cycle, platelet clearance accelerates. So it's a kind of interesting phenomena that it just upregulates, for some reason, the ability to have antigen-related antibody clearances. So it upregulates the phagocytosis mechanisms that seem to shorten the half-life. But why they develop the autoimmune disease is another story. And people have been looking at why estrogens could play a role in that. But it may be related for other reasons to the same reason why they have enhanced phagocytosis, that there's a different cytokine mechanisms that are triggered by estrogens that lead to enhanced phagocytosis and immune regulation that allows escaping clones, as we call them. Yes.
I just have a, first of all, very nice talk. I'm a gastroenterologist, so receptor agonists all the time to try to transiently bring up the platelet count and advanced cirrhotic briefly perform endoscopic intervention like banding, for example. I don't know if there's, I mean, the real downside to them is that banding, we need to bring the patient back to have a second look endoscopy, possibly be banned. You see it in women, I mean, realistically, the platelets are there, they're in the spleen, they don't come out when I need them.
Yeah, I mean, as you know, one of the drugs, Therapeutic, was first approved for procedures in patients with cirrhotic liver disease. The issue here is the issue of two things. One, yes, you can get the platelets up. You can get them up over 50,000. It's reasonably safe for those type of procedures. But also you enhance the thrombotic risk. There's no doubt about it. Thrombopoietin failed its trial to be used in liver disease because there was portal vein thrombosis, which is a problem with advanced liver disease independently. And so you have a problem there of the choice of thrombotic complications and portal vein thrombosis if you're trying to prevent that. And where you have portal vein thrombosis, you have the risk of extending into the superior mesenteric, vein. You've got problems there too. And those are the patients that end up wanting to anticoagulate because of that risk. So it's a complex story here of one gain versus the potential risks that are involved. So long-term use of TPO agonists, even in ITP, there's some data that it does increase thrombotic risk. There's no doubt about it. Probably 2 points. Venous risk is due to the inflammatory disease. ITP had an increased risk of thrombosis all along, okay? But at high platelet counts in the romiplosin trials, that's where you saw the arterial events, which is not surprising, particularly since this can be a disease of older people. Liver disease and cirrhotic liver disease puts you at risk of portal vein thrombosis, part of the evolution of the disease. So here you got a prothrombotic value, which is in the splanchnic system, and you put and raise their platelet counts, then you got a problem there. So that's why I think you're stuck doing just intermittent raising the platelet count to a safe level. So I think you're kind of trapped in that situation. I don't think there's any long-term way to resolve that problem.
Thank you for highlighting the issue about the increased risk of thrombosis.
Well, the funny story is that when I was at USC, there were two major departments. There was hematology, the great Sam Rappaport, because he developed the PTT tests and discovered, tissue factor pathway inhibitor, et cetera, et cetera. And then there was Telford Reynolds. And so Reynolds was convincing me I should be a hepatologist, and Feinstein and Rappaport said, no, you should be a hematologist. So when I got my first paper in the New England Journal, which was the des-gamma carboxy prothrombin marker for hepatocytic carcinoma, which is still used today, mostly in Asia. Interestingly enough, Reynolds wrote me a paper saying, I knew you were going to be a remember, it was hepatohematologist. So I guess I'm first liver over blood. All right. Other questions? This isn't, yeah, go ahead. There are potentially differences because of the complexity. Example, in Evans syndrome, okay. Big question is, are there differences between the secondary ones that were listed there and primary? Yes, there are complex issues because, example, many patients with lupus also have the antiphospholipid antibody syndrome. Many have had thrombotic cases and have ITP. It adds the complications of managing someone who's on multiple drugs. And so the response rates are varied. But even example, in Evans syndrome, we see patients with Evans syndrome that you treat, and they have complex genetics. We have an LAB1 mutation that's involved in the CTLA4 system, that is the suppressor system of the immune system. We have another patient who's got a, IKZF1 mutation that's common virulent deficiency. So there are all these heterogeneities in the background of genetics. The more complex the secondaries you're more likely to see. In the infectious ones, though, patients with HIV, many of them respond to heart alone. In H. pylori, we've shown in a paper by in our group, treating them early, you can get long-term remissions. Literally cures. Because I have patients that are 12 years after treating H. pylori. And in the patients with hepatitis C, in an original paper by Sandeep Rajan it was in the American Journal of Hematology, independent of the paper about the incidence, he showed that many of those patients respond to treatment of hepatitis C. We still see patients who are treated early on for hepatitis C and will develop ITP, but still some patients, the incidence is falling. In our hospital, the incidence of seeing ITP-associated hepatitis C has fallen with early treatment of hepatitis C. So, I think that's a unique group that really strategies that you can approach it, that not necessarily immune by affecting the target entity, be it HIV, hepatitis C, or H. pylori. Yes. Any difference in treatment response? Well, first of all, there are two things there. One is patients who get de novo ITP. And in reality, they respond like anybody else, interesting enough. And most of them get responses. And at least half in our experience, we've seen long-term remissions that are off treatment. But some patients still have ITP. And that just is that, again, vaccines can bring out escape clones and affect this. The older patients tend to have a much more difficult disease if they get it. Then there's a second group who have had ITP in remission or on treatment and get vaccination. And 9% will drop their platelet counts, less than 30,000. And that's published in Blood. It was a multi-center evaluation of our cases and their cases. But interesting enough, 9% will send their platelet counts up because the inflammatory interleukin-6 is the thrombopoietin receptor agonist. So we had one woman who's been in remission many years, post-splenectomy. She failed splenectomy. We put her in remission with mycophenolate. So 5 years afterwards, she gets her vaccination. Finally, I convinced her to come in after she got a second vaccination. She didn't come in after the first one. I was worried about her. Her platelet count when she came in was 1.2 million. She's on no treatment, but she has no spleen. So again, inflammation and interleukin-6 is a good thrombopoietin agent. And so those patients obviously can go either way, up or down. Okay. All right. Thank you.